So today here I am in front of you to discuss a very important topic in the gastrointestinal tract, that is inflammatory bowel diseases. Now we have two main inflammatory bowel diseases, ulcerative colitis and Crohn's disease. Now today we'll discuss all the differences and how to identify which disease is the Okay, now Crohn's disease and ulcerative colitis. It's very easy if we compare both the diseases because they have some similar features and some dissimilar features. Now both are a form of inflammatory bowel disease only. But the difference here is the first important point, ulcerative colitis and Crohn's disease. This Crohn's disease affects, it's a transmural inflammation from all the part of GIT, that is mouth to anus. It's a very widespread disease from mouth to anus. Any part may be involved. So if the mouth is involved, oral aphthous ulcers can be a presenting feature. If the anus is involved, we'll have to, depending on the affected part, there will be features. General features like weight loss, fatigue are also present. Diarrhea is a common feature to both types. However, now here, okay, let's discuss ulcerative colitis. Ulcerative colitis typically affects the rectum region, so it is a disease of the large intestine. Now, when rectum is affected, or sometimes colon also is affected. Here, the inflammation is called transmural inflammation because it affects the entire GIT and also all the layers, that is serosa, submucosa, mucosa, muscularis. All the layers are affected here. While here, the inflammation is confined to mucosa and submucosa only. So, it is a superficial inflammation. Now, the other important differentiating feature is intestinal obstruction is present here and here also. Now, etiological factors, here bacteria are also thought to be an etiological factor in the causative of Crohn's disease. So, we have in the treatment when we are discussing, antibiotics tend to play a role in Crohn's disease treatment. Also, now let's discuss about diarrhea here because it's very important to differentiate, and in questions generally it will be a differentiating feature also. So, diarrhea, here it is a non-bloody diarrhea. And in ulcerative colitis, it is bloody diarrhea. So, let's not get into the details why and all, but to remember easily, just remember ulcer bleeds. Generally, ulcers tend to bleed, so ulcerative colitis is bloody diarrhea. Crohn's disease is non-bloody diarrhea. Okay. The next very important features are extraintestinal manifestations. Now, extraintestinal manifestations are present both in ulcerative colitis and Crohn's disease. However, why they are present, what are they? Everything is important with respect. So let's discuss again in two different comparisons, ulcerative colitis and Crohn's disease. So the first extraintestinal manifestation is related to skin. So skin, erythema nodosum and pyoderma gangrenosum. These are the two very important extraintestinal skin manifestations. Now this pyoderma gangrenosum is generally more common in ulcerative colitis than in Crohn's disease. Right, now the next extraintestinal manifestation is related to the eye. So we have scleritis, episcleritis and uveitis. However, for exam point of view, uveitis is very important because it's present in a majority of people with inflammatory bowel disease. But this also is present more commonly in Crohn's disease, ulcerative colitis. So, how to remember this? Again, there's a mnemonic here, U and U. So, uveitis starts with U. So, it is more common in ulcerative colitis. It is present in Crohn's disease also. Now, the next part is related to malabsorption. Okay. Yes, malabsorption. Now, malabsorption, why this malabsorption is occurring? Let me clear all this and then we can have a neat look. Okay. Now, if we take this is the stomach, duodenum and all. So, okay, I'm not so good with diagrams, but let's say this is the terminal ileum. So, near the terminal ileum, we have two things that are absorbed here. One is B12 and the other one is bile acids. So, both start with B. You can remember it that way. So, these both are getting absorbed from the terminal ileum part. And here we have iron and folic acid is absorbed here. Okay, so now Let's see. Now, Crohn's disease. What is the basic pathology here in Crohn's disease? It's a transmural inflammation, right? That is, all layers are affected. Also, from mouth to anus, any part may be involved. That's what we said. So, this all, the entire GIT might get affected in Crohn's disease. Now, suppose this part is getting affected. The terminal ileum is affected, and there's inflammation of the terminal ileum. So, B12 and bile acids cannot be absorbed. So now, serum B12 level will reduce. Okay, and suppose bile acids are reducing now. These bile acids, they actually, here if you have the liver, these bile acids go to the liver and they help in absorption of fatty acids. Now this is a different, altogether different topic. It's called enterohepatic circulation, but just to brief the circulation here, it's useful for absorption of fatty acids like fats. So, if bile acids are not absorbed properly, and bile acids are excreted in the feces now here, because there is no absorption, because the entire wall has been inflamed due to the disease process. So then what will happen? All the bile acids are excreted in feces. Now fats cannot be absorbed. So these fats increase in the body. Now, because of this, so defective absorption of fats, it leads to steatorrhea. So this fat is also increased amount of fat are present. They are excreted and it leads to steatorrhea. And now another very important point here is the ratio of cholesterol to fat bile acids also increases. Why? Because there is no absorption of bile acids. So bile acids are all getting excreted in the feces. So obviously the ratio will increase because the denominator is decreasing. So this will lead to cholesterol precipitation. Now this cholesterol will precipitate and form gallstones, a very important feature. Why gallstones are occurring? Due to precipitation of cholesterol. Why cholesterol is getting precipitated? Because of defective absorption of bile acids. Now these gallstones are cholesterol gallstones. That is a very important point we all should remember. Another important point here is now because these bile acids cannot be absorbed, there is also steatorrhea is present. And if suppose here the defect is here, it can affect, as we said, the entire GI tract can be affected. So if there is defective iron absorption, it can lead to iron deficiency anemia also. So the type of anemia here will be macrocytic anemia. Yes, continuing our discussion here. Now, because this B12, let's continue with B12. Now, B12 and bile acids, both are not being absorbed. Both are absorbed from the terminal ileum. So, because of the disease process, bile acids cannot be absorbed and it leads to steatorrhea, malabsorption of fat, and also precipitation of cholesterol type of gallstones. And apart from these, there's a very important feature here. Normally, in normal individuals, the calcium is bound to oxalate. Okay, these are they are like good friends, let's say. So calcium and oxalate are together. Now here, due to precipitation of this bile acids, what do? They help in fat, they absorb fats, increased fat absorption. Now here, increased fat precipitation is present because bile acids are very deficient. They are all getting excreted in feces because they can't be absorbed. So all these fats, now the fat has to bind to something. So this calcium will dissociate from oxalate and it will go and bind to the lipids. And it will form a complex. Okay, it will form calcium complexes and some emulsion, micelles, they are called micelles. So all these molecules are formed and this oxalate is left now. So this oxalate is reabsorbed. Normally oxalate is excreted along with calcium, but now calcium has dissociated and it went and bound to lipids. So now this oxalate gets precipitated and it leads to the formation of kidney stones, that is oxalate type of kidney stones. This is again a very important feature. Another important feature is the risk of cancer formation. Now colon cancer, the risk is much greater with ulcerative colitis than in Crohn's disease. How to remember? This is also very easy because ulcerative colitis is typically an inflammation of large intestine confined to the rectum region. So colon is also part of rectum. So colon is a part of large intestine. So more risk with ulcerative colitis. But Crohn's disease is a from mouth to anus, any part can be affected. So the risk is comparatively lower. So three important points to remember: uveitis, which is an extraintestinal manifestation, more common in ulcerative colitis. Pyoderma gangrenosum is also more common in ulcerative colitis. The risk of colon cancer is also more common in ulcerative colitis. In the class, there are some very important features for exam point of view, which are related to the disease activity and which are unrelated to the disease activity. Now, each of the extraintestinal manifestations, let's go. The first one related to eyes, we have three features: episcleritis, scleritis, and uveitis. So, as we know, uveitis is more common in ulcerative colitis. Now, episcleritis is a very important manifestation which is related to the disease activity. Right. The next feature being, let's discuss about skin. In skin, we have two important manifestations: erythema nodosum and pyoderma gangrenosum. So, erythema nodosum is again related to disease activity. Pyoderma gangrenosum is not related to the disease activity. Now, let's discuss about joints. In joints, we have asymmetric involvement and symmetric involvement. Asymmetric involvement is related to disease activity, and symmetric involvement is not unrelated. Symmetrical involvement is unrelated. So, whatever are unrelated here, the rest ones, that is, uveitis is unrelated to disease activity. Next is symmetrical joint involvement, and erythema nodosum is over here. So you have pyoderma gangrenosum, and related to these are the important features: primary sclerosing cholangitis. This is also unrelated to disease activity. As we know, this is also more common in ulcerative colitis than in Crohn's disease. Now let's see about investigations. Investigations which are investigations first with respect to Crohn's disease. Let's see. Now in Crohn's disease, investigations first. As we know, terminal ileum is affected, so B12 bile acids are not getting absorbed. Iron is also not getting absorbed because any part can be affected. So let's now, because iron stores are deficient, it can be iron deficiency anemia, that is macrocytic anemia, and now B12 is not getting absorbed, so decreased serum B12 levels. It's a type of inflammatory bowel disease, so increased inflammatory markers along with fecal calprotectin levels are also increased. There is a decrease, generalized malabsorption is present, and vitamin D levels also can be decreased. So apart from all these, specific investigations like in blood, if you do CRP, okay, these CRP is very important because it tends to correlate with the disease activity. Also in endoscopy, if you perform endoscopy, we have some skip lesions and deep ulcers are present. Why deep ulcers are present in Crohn's disease? Because all layers are getting involved from mucosa to serosa. Why skip lesions are present? Because this is something like the skip lesions. Okay. Because see, till down it's getting inflamed, and some normal mucosa, again the inflammation till down, and it's the normal mucosa. So because of these, it's these are called skip lesions, and this pattern is also called cobblestone appearance. So this is present. This is all on endoscopy. Okay, now after continuing our discussion, right, histology. Now, histology, a very important point here is the presence of non-caseating granulomas. Okay, granulomas are very infrequent in ulcerative colitis, they do not occur. Also, the same region, ileocecal tuberculosis tends to be affected, like mostly in the Asian countries, but it's an important differential diagnosis. In tuberculosis, you can distinguish based on histology itself because it presents with caseating granulomas. Also, goblet cells. Now, important point with respect to goblet cells is goblet cells are decreased in Crohn's disease while goblet cells are increased in ulcerative colitis. Okay, now small bowel enema. Small bowel enema is highly sensitive and highly specific. Okay, especially in the terminal ileum, small bowel enema. Now, Cantor ring sign is a sign which is present here. And this Cantor ring sign is somewhat similar to the string on bead appearance which we see in endoscopy. Okay, and proximal bowel dilatation is also a very important feature. Right. So now in a nutshell, now difference between ulcerative colitis and Crohn's disease is that in Crohn's disease we have adhesions, abscesses, transmural inflammation, all wide range of clinical features. But in ulcerative colitis, no granulomas, no abscesses, no fistula formation, and inflammation is only up to the superficial layers. Diarrhea, remember ulcer for bloody. So ulcerative colitis, bloody diarrhea. Also smoking. Smoking is a protective factor for ulcerative colitis, while it's very harmful in Crohn's disease. It tends to exacerbate the condition. Site of inflammation. Okay, Crohn's disease from mouth to anus, any site. Ulcerative colitis, rectum is the most common site.